Call the meeting to order. Please rise. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Welcome, everyone. Catherine, would you please take the roll?
Director Wallace.
Present.
Director Nicholson.
Present.
Director Stewart.
Present.
Director Danielson.
Present.
Present. Thank you. Nancy?
Tonight, we have two education sessions scheduled. The first will be on the subject of our Aetna contract, and here this evening to speak to the board is Noah Rosenberg. He's a partner in the law firm of Rosenberg and Kaplan in Southern California. He's been counsel to Washington Hospital in the area of managed care contracting for the last 25 years. He received his Bachelor of Arts degree with honors from the University of Wisconsin in Madison in 1972, and he earned his JD with high honors from Loyola University in Los Angeles in 1980. He advises physician groups, hospitals, hospital systems, physician hospital systems, and physician and hospital trade associations in all facets of healthcare law, including but not limited to private and governmental third-party payer contracting. And he works with businesses and helps them with corporate matters as well. He is a frequent lecturer to hospital, physician, and employer groups on diverse subject areas relating to healthcare reform, the design, development, and implementation of healthcare delivery systems, the design and development of hospital-physician joint ventures, the design and development of strategic plans, and all forms of contracting. He has served as the host of the Hospital Satellite Network's Executive Options, which was televised in over 300 hospitals nationwide. He was recently identified by the National Law Journal as one of the leading managed care attorneys in the United States, and by the California Law Business Journal as one of the leading healthcare attorneys in the United States. With that, I'd like to hand the program over to Noah Rosenberg.
Thank you very much. Can everybody hear me okay? Terrific. Thank you, members of the board, Nancy, members of hospital administration, members of the public. It's my pleasure to be here tonight. I consider myself to be a resident of Fremont since I've been working with the district almost since birth, I think, or pretty close to it. But it's always good to be here with friendly faces and people who I really think care about the district. And I'm going to talk tonight about a tough situation, not easy for people who are residents of the community, not for physicians, not for administration, the board, and frankly the community at large. A tough situation, and that is the current situation with Aetna health plans. Just some general remarks at the outset of my remarks, and please feel free to ask a question or challenge or charge the podium whenever you'd like. I'm pretty good at that usually. And that is, what is happening in this post-Accountable Care Act, Obamacare, I'd almost say rampage. And essentially in the last 2.5 some odd years, when I was in New Delhi, India, and read about the war going on between Anthem Healthcare and the Obama administration about accountable care, and people in India would say, why can't you guys ever get along with each other? So literally, since that point in time, frankly, healthcare has been turned up on its head, on its ear. You have, frankly, a significantly greater number of uninsured and underinsured today than you did 2.5 years ago. You have doctors and hospitals who, frankly, are fighting for survival. You have residents who are now looking at lesser premiums because of health care. No. Actually, quite a bit in the other direction. Healthcare premiums in the state of California, certainly in Northern California, have gone up double digit and gone up in a very, very aggressive double-digit fashion. You've got health plan premiums that actually don't reflect the kinds of insurance that you're getting because simultaneous to actually seeing dramatic increases in premiums, you're seeing dramatic reductions in benefits. So people are paying a lot more for lesser benefits. So one of the big problems, frankly, for individuals who buy insurance, and a huge problem for the hospital industry as well as the physician industry, are high copay and deductible plans, where members are now stuck with what might have been 5 years a zero premium, or I should say zero deductible or copay. Now that could be $100. So it's not uncommon that I'll have large medical groups that I represent, pediatric practices, and say mom came in, dad came in with 4 kids, and to actually get through the door was $400, whereas 5 years ago it was $40. So if anything, what you've seen, at least my observations, and these are my observations, and frankly all my comments tonight are my comments and those of my practice, is a healthcare environment which is in tremendous turmoil and changing on a regular basis. We all waited for the U.S. Supreme Court to come out with a decision on the Accountable Care Act 2 weeks ago, and we flipped 5 minutes from the beginning of the program to the 5 minutes into the program. We had 2 decisions. We had one, Obamacare was overturned, and then that was CNN, and 5 minutes later it was supported. So essentially, all the commentators, frankly, missed some very significant elements to the Supreme Court decision, because what the Supreme Court decision actually did was to narrow the power of the federal government to do a whole variety of different things. And what the Supreme Court also did was overturn the portion of the Accountable Care Act which expanded Medicaid, which was one of the showcase pieces or portions of the Accountable Care Act. So now we're faced, certainly in California, which is we're always more left, more liberal, we're always more open to broader benefits. We're faced with 6 million people who were going to come into the healthcare exchanges in 2014, 3.2 million above the federal poverty level of 133% of federal income, or of what the poverty level would be, and 2.8 million Medi-Cal. Now we don't know, because it looks like with no expansion of Medicaid perhaps in Arizona, with no expansion of Medicaid perhaps in Nevada, I'm sure we'll get it up in Oregon, what you have is many people who unfortunately are unemployed, the Medicaid population or the new eligibles, who could literally walk across the border, rent an apartment, open up a utility bill, and qualify for Medi-Cal benefits in the state of California. So all of which is coming out of whose pocket? Members, hospitals, doctors, taxpayers. So a very difficult environment, and once again showcased on the health plan side by much higher premium increases and record profitability. While I was preparing for tonight's presentation last night, I looked up Aetna's profitability. All I have to do is Google Aetna quarterly profits. And Aetna health plans at the close of 2011 fiscal year, calendar year, I think they matched their fiscal and their calendar, had an increase in profits of something like 74%. Just huge, huge increases in profits. First quarter, that kind of slowed down, but still making a huge amount of money on health insurance. The other thing that you're seeing in the market, by the way, is as more employers cannot afford insurance, they're going self-insured. And that's important for those of us here in the community that take care of people, simply because the kind of patient that you're seeing in many instances is not one going out into the future that actually has insurance. The employer is actually paying as you go. They're not buying a traditional insurance policy. What about Aetna Health Plan? Aetna Health Plan is one of the smaller of the major health plans in the state of California. And when I say major health plans, there's typically 5 or 6 that people talk about. Certainly the giant of the non-Kaiser milieu would be Anthem, Blue Cross. That would typically be number 1. Number 2 is probably going to be United Healthcare. in United Healthcare, not only because of its HMO, but its PPO and its Secure Horizons Medicare Advantage product. And United Healthcare also has, through Optum, one of the largest transplant networks in the world. Something like 25 million people alone are covered by United's transplant network. So you've got Aetna, where? Down around 4 or 5. Anthem, United, Blue Shield, HealthNet, Aetna, Cigna, Aetna, somewhere in through there. So you're not looking at a major health plan in the state of California. And in the state, largely what they're selling is a PPO point of service type of product. They're not a predominantly HMO model. The HMO model, frankly, is and has been on the decline in California for a number of years. I can't say it's 3 or 4 or 5, but you've seen dramatic reductions in the number of employers that are actually buying HMO insurance for one basic reason. Under California auspices, Woody Allen would say, Californians are always different. We have a agency called the Department of Managed Healthcare, which specifically regulates Knox-Keene health plans, or HMOs as we would call them. And we have a very strong statute in California that's called mandated benefits. So if you're going to buy an HMO policy, the law requires that you buy a fairly aggressive set of benefits. So more recently, the state now added autism to one of the mandated benefits that people who buy, employers who buy HMO coverage will have to offer. That's very expensive. So more and more employers shifting to the PPO side and to the self-insured side, in large part because you can move out of mandated benefits and you can have a lot more to say about what you're offering your members. But Aetna, largely a PPO point of service type of health plan. Point of service, basically an HMO lookalike where the patient is really free to go wherever they want, as well as in a PPO model. And you have what's called an in-network status where the member has a contract, or I should say the hospital or the doctor has a contract, and an out-of-network status where the doctor and the hospital do not have a contract. But the member clearly under a PPO and a point-of-service model can choose to go in-network or out-of-network. They just have a higher financial responsibility if they're going to go out-of-network. And that will go, remember that, because that's going to be very important when we're talking about what Aetna's doing in this particular community. The difference between PPO and point-of-service, where members can go in and out of network with different benefit levels, as opposed to HMO, where you're really talking about a closed system, and members have to go in, otherwise there's no benefit going out of that network. So PPO point-of-service membership base. The Fremont position, the district's position is no different. Here at Washington Hospital, we basically have Anthem as our major carrier, major insurer. We have clearly United as a major insurer. We have Blue Shield as a major insurer. We have HealthNet, but keeps declining. And I do believe that Aetna is pretty much at the end of that ladder, just in terms of physical numbers of individuals who choose to get their insurance or buy their health care benefits through a particular health plan. And here there's no difference really. We have a lot of point-of-service members and what they call, and that's quite a bit different than point-of-service, it's called managed care choice or managed choice. And what that is a similar concept where you can choose to go in-network or out-of-network, and these are very generic descriptions, and there's a different level of benefit based upon if you go to an in-network, meaning a contracted provider, or out-of-network, which means non-contracted provider. So I would tell you that that's kind of a picture of Aetna. Now, I would tell you that in the last 2 years, we've had some very, very, very difficult negotiations at Washington Hospital with some of these major carriers. I believe the last time I stood in front of the board and the community, the televised meeting, was when we had a discussion of a potential termination of the Anthem Blue Cross contract. And I'm certainly happy to say that through a lot of hard work by Nancy and Nancy's staff, What we have is a multi-year agreement with Anthem Blue Cross, a good relationship with Anthem Blue Cross. And, what I did find, and I think we all found, is although they were tough, they were flexible. They had certain needs and certain requirements that they had to meet, but they were open to a conversation. They were open to a discussion. Same thing true of United. That negotiation was not fun. United was actually coming to the minutes of these televised meetings and quoting us, what happened at particular meetings. They have a tendency to do that. But once again, although a tough negotiation, a fair one. Flexibility on both sides, an open discussion. Was United and was Washington, were we both elated about the results? No, we weren't elated about the results, but we maintain the relationship, we have a good working relationship, and we move on. Now, both of those plans, and those were the two more recent large, and those were very, very large negotiations. We focused in on some pretty moderate rate increases, not which I'll go through in detail here, but clearly tempered. And once again, because that's the Post-Accountable Care Act passage, where although profits are up for health plans, although premiums are up, essentially when the carriers come to the table, they're very tough now. And what they'll say is, we're no longer going to pay those kinds of trends. We have to get, some significant pricing breaks. We need to have a really slowing down of the escalators on cost and price from the hospital, and that's no different here than it is at any hospital in the state of California. So modifying trend is very important. Big difference, however, with Aetna. And I have done quite a few negotiations with Aetna over the years, and more recently, quite a few. And Aetna, from my own perspective, doesn't negotiate. It's a new perspective, and it's a new Aetna, really, because this is not the way Aetna health plans did business, frankly, even as much as 12 months ago. And the way they appear to be doing business is they use outside consultants. Those outside consultants, in some shape, form, or fashion, think they've determined how our pricing is or what our pricing is in relationship to all the other health plans. It's not like we openly give them our Anthem and our United and our Cigna and our Health Net contracts. Of course we don't. But they do some complex analyses and come out with data which is frankly wrong. And what they do, and that's already occurred to Andrea, in a meeting that we had with Aetna on June the 4th, what they'll do is they'll come in and say, okay, our consultants have determined that you are disadvantaging us in the market by X%. And this is what your contract's going to be. Well, what about a negotiation? No, our consultants have determined this is what your reimbursement's going to be. Now, I have to tell you, given their market position throughout the state, that has not, frankly, been a very good negotiating tactic for them. And because of that, once again, it's our way or the highway. That's essentially the mantra that Aetna Health Plans has taken in certainly my negotiations. You have seen a very large number of significant terminations of Aetna Health Plan contracts. Down the road here at CHOP, Community Hospital of the Monterey Peninsula, similar tactic. That then resulted in a termination of the Aetna contract, and from everything I've heard, amounted to Aetna losing, from what I'm told, most of their membership in Monterey County. St. Rose, just up the street, actually terminated the Aetna contract sometime September, October of last year. Now, I have to tell you, I don't know what St. Rose's rates are, but I have a pretty good sense as to what they might be, just based upon what other health plans have told me. I certainly haven't seen their contracts. Their rates are significantly lower than yours, significantly lower than Sutter's, significantly lower than CHW's, just because they have no leverage in the marketplace. And because they just didn't do a very good job, frankly, in negotiating their contracts. If I'm Aetna, the last thing in the world I want to have happen is for St. Rose to go to termination. Why? Because if St. Rose goes to termination, where do the patients go? The patients have to come to Washington, or the patients have to go to Eden, or the patients have to go up the road to Sutter, all of whom are going to be more expensive. It doesn't make any sense from the standpoint of what the plan pays, and it makes absolutely no sense from the standpoint of the community members, people who live in that community, because they're going to be paying a lot more for some of the very same services they could get at St. Rose. Adventist Health in Southern California is a good client. They are terminated. Frankly, just a matter of time before Adventist Health, more likely than not, in Northern California terminates. Good Samaritan Medical Center in downtown Los Angeles. Once again, a medical center, which is a very good medical center, but where do the patients go in the event Good Samaritan terminates? They go to Cedars, they go to UCLA, all of whom have significantly higher rates. So the strategy doesn't work for Aetna, or at least nobody quite understands why it does. And the strategy, more importantly, does not work for members who are disrupted, who can't go to their doctors, and certainly can't go to the terminated hospitals. But what you have is hospitals that are willing to say, if you're going to treat me like that, then I'm out. I'm out of the network. So essentially, in those terminations, quite a few of the members actually keep going to those medical centers. Why? Because many of the patients are actually going to the hospital through the emergency room. And there's really nothing Aetna can do about that. And also, Aetna typically uses shadow contracts with some other third-party preferred provider organizations. And so they actually have rates with other organizations that they can access. But they're typically at a significantly higher rate level than the actual contracts they have with the plan hospital contracts that are terminated. So many of the patients, maybe 50%, I don't know the exact number, are continuing to come, and it's costing Aetna a significantly greater amount of money to provide the care to a much smaller population of patients. Once again, probably in the 50% range. Now, what's also happening is Aetna, for some reason, has it in their mind that, and I'll call it what it is, I guess it's the New York in me, they're sending out letters threatening doctors. They're sending out letters saying that your contract with me, doctor, says that you have to admit to a participating hospital, and guess what? If your hospital terminates and you have exclusive privileges, that necessarily means to say you're only going to be able to continue to admit to that terminated hospital. And so we're going to terminate you. And it's done in a very crude, non-relationship building concept. And it's done in a way that here's the letter, even though you might have a relationship with me that goes back decades, you're gone in 90 days. Or whatever the time frame is. Now that has precipitated tremendous ire among physicians in the state, and currently there's at least one class action lawsuit that's being filed on behalf of the California Medical Association, several, I think the Ventura Medical Society, the LA County Medical Society, and quite a few plaintiff physicians with a whole host of allegations that range from the following. Most of the patients that are coming to these doctors and hospitals that, remember, are PPO, or point of service, they're physically buying an insurance premium that allows them to go to an out-of-network provider. Okay? So, wait a minute. I bought a PPO plan. I can choose to go to an out-of-network provider but pay more. Why is it that the doctor who I go to is being terminated, because doesn't that take away my right and my ability to actually take advantage of my policy that I'm paying for? If I wanted to be restricted as a member, I'd buy an HMO policy that said I had to go to this group of doctors and this hospital, and that's it. So the litigation essentially surrounds a whole range of different things, and it's not, we're not doing the litigation. Revolves around breach of contract, interference with contract, a whole host of allegations made regarding patients buying policies that they're not getting the benefit of. So there's quite an uproar now in the physician community statewide, more so in certain pockets than others based upon where there's an actual termination. But I think you're probably going to see a greater amount of activity in that particular domain. Well, what's happened here in Washington? We actually have two separate agreements at Washington Hospital. They were both entered into in 1994. We have one that's called an all products contract that essentially covered everything except HMO. Literally everything except HMO. So it covered PPO, it covered what's called exclusive provider, it's called point of service, etc. And then we have, once again, entered into in 1994, around the same time, an HMO contract. And that HMO contract is governs how patients come to Washington for HMO policies. And the payment guidelines in either contract are quite a bit different. They're quite a bit, they're more expensive on the PPO side. Why? Because the premiums are higher. We understand why the premiums have to be higher when somebody wants more access. The HMO premiums are typically lower, once again, because you have restricted access. So essentially what happened here beginning this spring was Aetna decided that our rates were too high. From the standpoint of they're too high? No, because the outside consultant that they're using determined that we're unfairly disadvantaging Aetna in relationship to Anthem, United, HealthNet, Cigna, Blue Shield. Once again, did we give them copies of our contracts? No. Just different models, methodologies, mathematical calculations, which led them, the consultants for Aetna, to say that they're paying more than the others, which I will not disclose what the rates are. Certainly that's not appropriate. Those are subject to confidentiality terms, but I would tell you that Aetna is not disadvantaged in the market. They are not. And what Aetna said going into our meeting on June the 4th was, okay, we're going to rectify the situation. Thank you very much. You're going to rectify the situation. That means it's going to cost Washington money. So essentially what they said is, based upon our calculation of how we're disadvantaged, we're going to send you a proposal that does what? That says on the PPO side, we want a different structure, we want more rate predictability, and we're going to radically reduce your rates for PPO. And on the HMO side, even though we had not gotten an increase on that contract for 12 years, 12 years, I don't think Aetna's premiums have been static for 12 years. I would surmise their premiums have probably gone up well over 100% on different products during that time frame. Even though we had not gotten a rate increase for 12 years, we weren't going to see, according to them, much, if any, increase on the HMO business. Once again, reimbursement for the PPO products to us is quite a bit higher than reimbursement on the HMO product. So they went ahead and did what? They said, we're terminating your contracts. So the first thing they did was to terminate our PPO, our all products contract, our PPO contract, and that termination effective August 1st. But for some reason, they didn't terminate the HMO contract, and we're wondering, maybe they didn't do that because they think they can run all the business through the lesser paying document. Well, it didn't take but a month or so until, for some reason, they terminated the HMO contract also. And the effective date on the HMO contract termination is October 1st, or the end of September. So essentially, they then send us a proposal which represented a huge, huge, huge double-digit reduction on reimbursement to the district. Now, mind you, huge double-digit reduction because they're disadvantaged in the market, while last year they reported a 70+% increase in profitability, and the numbers of the hundreds and hundreds of millions of dollars they made are staggering. I'd love to be able to say that Washington made that kind of money and then it just put that back into the community, but it's tough. Certainly the board and administration knows how tough it is. The significant amount of indigent care we provide here, the significant amount of Medi-Cal care that's provided here, the huge repository of patients that come through the emergency room. We support care, you support care for your residents. And we don't see ourselves making these millions, tens of millions, hundreds of millions of dollars. So essentially, what was occurring at the same time is not only are they terminating our contract, but they owe us millions and millions and millions of dollars. I always get a kick out of contracts where a health plan says, your rates are so high, we've got to take care of your rates. It's kind of like, well, if you didn't pay us, were our rates really that high? It's not, an Einstein kind of concept. It's not like the theory of relativity. If you don't pay us, our rates aren't so high. In fact, you probably have pretty good rates. In fact, we had one case that goes back to November, and it was just a horrible case where a woman who eventually succumbed to Washington's physicians did whatever they could possibly do to keep the woman alive. That, end of care, that's where you start. That's where you see the expense. That's where you spare no expense because you're trying to save somebody's life. Well, when I tell you just one example of them not paying us, that care in and of itself to us was north of $1 million. We have not received 1 cent on that claim since November. Am I understating that?
You're correct.
Not 1 cent. From my standpoint, a violation of any concept of what's ethical, and frankly, a violation of what I would consider to be what the law requires them to do. Now that, in conjunction with many other claims that they haven't paid, and a whole host of other reasons and ways in which they frankly have not paid us according to our contract. So a pretty big nut for the board and administration to swallow when you've got an Aetna contract, which is a relatively small patient population, an Aetna contract where we have not received an increase on the HMO side for 12 years, an Aetna contract that has not paid us millions and millions and millions of dollars, and they're terminating us. I guess I have a different sense of psychotherapeutic anything. I mean, it just doesn't make any sense. And I've been in this business for 32 years. As people know, I used to have hair and I used to have a mustache. This is my first Washington board meeting without a mustache. Last time it was without hair. So, and I can tell you that managed care has had a lot to do with that. So, at the end of the day, we have a plan that is accusing us of A, B, C, D, E, and whatever it might be. And what else are they doing? That's not enough that they're doing that to the institution. They take it upon themselves within the last week to 2 weeks, where now they're deciding that, as they have done in other parts of the state, we're going to do the same thing with X number of doctors. I think it was over 80 doctors who exclusively admit to Washington. And we're going to send them a letter, and we're going to terminate them too. Now, did those doctors do anything short of provide excellent care? No. Did those doctors have contracts with Aetna, some of them for decades? Yes. Were the doctors charging exorbitant fees? No. And they're being terminated? What's that message all about? Once again, the message is, to me, a leveraging message. Let's try to turn the doctor against the hospital. Let's try to create that leveraging point. And more recently, as I understand, it's either today or yesterday terminated the health guard Aetna contract, which I don't know, goes back quite a few years, into the 90s or something like that. So it's not only the institution, but to me, the principal clients of any institution are the doctors. Doctors admit patients, and of course the patients. So now it's not good enough for Aetna that they come after the institution. Now they're going after our medical staff. So I find that nothing short, and these are my opinions, reprehensible. I could use other words, but I'm being televised. So at the end of the day, we have a very bad situation with a health plan that, frankly, we are doing what with? Well, just because they act the way they act doesn't mean that we have to act the same way. So, in fact, we did send them a counter just today or yesterday, that reflects what we consider to be or contain many of the elements of the things they're looking for. They're looking for more fixed rates or rate predictability. They're looking for some relief on the PPO side. And oh, by the way, Aetna, we need an increase on our HMO rates, which once again have not been increased for 12 years. So, that went out. And we also have sent out more than one, I can assure you, demands for payment of money that's due and owed to Washington Hospital. So we have not said we're going to curl up and do whatever Aetna has to say. What we've said is we'll deal with you fairly, we'll deal with you up front, just like every other carrier. Even though, frankly, you're not every other carrier. You're absolutely not every other carrier. But Washington has, in the 25 plus years that I've been working, had the privilege of working with the medical center, has always said, don't terminate a contract, don't disrupt care of the community. That has been fundamental to the board and to administration. And honestly, that is not typical of hospitals in the state of California. Most hospitals in California today, probably over 90% of them, the first thing they do is terminate a contract. Washington, to its credit, does not do that. Makes it harder to negotiate, but at the same token, first and foremost, patients, doctors, community. Okay? So despite Aetna, we still sit at the table and try to negotiate. I wish I could say I'm optimistic over what that would frankly result in, but I can't say based upon Aetna behavior that I've seen throughout the state that will be the case. Second, as far as the claims are concerned, we're going to go after the claims. They owe Washington the money. This money is community money. This is not stockholder money. The money belongs to the district, period. That means it belongs to the community, and it's intended for the health care of the community. So it's our obligation, I would say as counsel, to go after it. So I've already identified a very competent litigation counsel to frankly proceed against Aetna full course. We've given them too much time and too many opportunities to pay. Washington has been submitting some of these claims to Aetna for years. Third, there is no question that, and we actually offered to Aetna, come with us to the regulators. Come with us and explain your behavior, certainly on the claim side. We will go together. You can't threaten regulatory action in California. You can't. But what you can say is, we have a problem. Maybe the regulator can be an arbiter, a mediator. Come with us and you explain to the state of California why it is that you think that it's okay for you not to pay us. Just explain it. If we're wrong, we're wrong. Okay, we'll have the no. They won't do that. So to the extent they've been offered that opportunity, and they have been, then we will go to the regulator. And we will have that conversation with the regulator. And in this case, there are two regulatory entities we're talking about. One is the Department of Managed Healthcare, which regulates HMO business. And the second is the Department of Insurance, which regulates the non-HMO business. Now, there have been some recent discussions, activity with the regulators, I think particularly Commissioner Jones, Secretary Jones, the head of the State Insurance Department, because there was some controversy, I believe, last year where Aetna, I believe, asked for a 30% rate increase. 30% rate increase. Remember, 70-plus increase in profitability close of 2011, and they're asking for a 30% rate increase? Something doesn't register. And they're asking for decreases from the hospital and doctor side? Something doesn't register. There's a disconnect there. Whether that 30% increase applied to individuals, small group, large group, I can't tell you. But typically most health plans today are getting much larger are asking for much larger rate increases for individual and small group employers, the most vulnerable of all employers. Individual is just a straight individual. Obviously, small group is an employer situation. So we are going to visit and meet with the regulators and talk to the regulators. Fourth, we will have a conversation because we owe our physician community for our relationship with them. We value that. That's important to us. That goes, and that's coming from a son of a doctor. People have called me the son of many other things, but at my core, I'm 62. I've been working with physicians for 62 years because my dad, just like Nancy's, is a retired professor of medicine, although not at Stanford, at another institution. So we owe our physicians, frankly, an obligation to do whatever we can to help them and work with them to the extent that anyone tries to antagonize, intimidate, or threaten them. That is not acceptable to Washington and this board. So to that end, we will have conversations with the California Medical Association at a senior level and see if they are willing or can get involved here at the local level. As I mentioned earlier, they're already counsel on a fairly large state lawsuit on behalf of a whole slew of providers. Last but not least, what do? We have to develop, and we have been in the process of developing a termination and a communication plan. We've got to let people in the community, doctors know, what are we doing? Okay? We have to let patients know, what are we doing? Because they're going to get a lot of conflicting information coming from Aetna health plans. They already have. They already have. I've seen some of the communications, and I would not characterize them as correct. Would I tell you that they're trying to deceive? No, I certainly would not do that. But I would say, to me, the communications that are going out contain a lot of what I would characterize as inaccurate information. I would tell the community the following. You come to us for care, we have an emergency room. You come to the emergency room, you get care. You get care. And I would also tell you that state law says the following. If a patient comes to the emergency room, there is a statute in the state of California that says they will get care, certainly from Washington's perspective, because the law says treat first, ask payment questions second, under both state and federal laws. But the health plans, Aetna in this instance, if their members come into that emergency room, they're on the hook for that care. And I would argue that one all the way to the U.S. Supreme Court. Might take a few years, but I would argue that. So I would say to the community, if you're ill, you've got a horrible event, you're sick, you need to go to the emergency room. We're open. We take care of the community. So to that end, I think that everything that I've seen, all the conversations I've had, certainly with Nancy, her staff, the board, is a hospital that first and foremost remains committed to the community and to the physicians and the members of that community. but faced with a very, very difficult situation. No question about it. Now, point of contact, as of this point, I have a name and a phone number to call. If there are any questions or issues, Andrea Demetras, Demetras, correct? Demetras, 510-791-3414. 510-791-3414. If there are any questions, issues, please pick up the phone and call Andrea. I can tell you she's got that Hawaiian spirit, and she'll give you the hana ho feel along with a good answer and a correct answer. So those were some of my thoughts, some observations about Aetna. Please, if anyone has any questions, challenges, or whatever or not, please.
John?
So, my name's John Romano. I'm the current chief of the medical staff.
Hi, John.
And so I just want to say, on behalf of the medical staff, thank you for your support and helping us and our patients. And secondly, before I left my office, I read a headline. I don't have any more information, just the headline that Aetna is also being sued in a class action suit by freestanding ambulatory surgery centers.
Surgery centers?
Yeah.
I wasn't sure, Dr. Romano, if that actually was a separate lawsuit. It's a separate lawsuit? Is that the way
I just saw the headline.
Gotcha.
Yeah.
Gotcha. Our pleasure.
Noah, what would you tell patients who have Aetna or small business owners who have Aetna? What should they do? Is there anything that they should do at this time other than observe for an outcome?
Well, Bill, the question's a really good question, and I can tell you where Aetna's been most vulnerable. They've chosen to do this going into the largest open enrollment for any health plan during the course of the year. That's why, frankly, it makes no sense to me on that basis. So what I would say to members is, it's our intent to try to work out a relationship, but frankly, based upon the way we've seen them do business, we can't tell them that we're going to have a contract. So we can say that we have a contract with Anthem. We have a contract with United. We have a contract with HealthNet. We have a contract with Blue Shield. We have a contract with Cigna. We have a contract with everybody. So what I would say, and so do our doctors. So to the extent that it's not looking good, I would say to them, take a look at your insurance. If you want to have Washington and its medical staff as part of that network, we have many other options. We're open and available, and certainly think it's a good idea for you to explore that.
Thank you.
Yeah.
Any other comments, questions? Thank you.
Thank you all very
Thank
much.
you, Noah.
There's one thing I'd like to mention. We've never canceled a contract in the history of the hospital. This will be the first time where we allow a contract to go to cancellation. It's never happened here before.
Interesting times.
The next subject is our annual budget presentation. And I'd like to make a few remarks before we have Chris come to the podium, our Chief Financial Officer. As the board reviews the budget this evening, I think it's important to take into account the environment in which the healthcare district will function in this coming year and beyond. We're entering a period of accelerated and highly disruptive change. Much of the change will stem from the Accountable Care Act, or the Affordable Care Act, that was recently upheld as constitutional by the Supreme Court. Some of the change that stems from this bill is already known to us, and we've been preparing for it. But there's also going to be change that comes to us in the form of the unintended consequences, which is a byproduct of change of this magnitude. And while the Supreme Court may have ruled on the constitutionality of the Accountable Care Act, the controversy is by no means over. Today, the U.S. Congress will have taken another run at it, a vote on the matter. It's another attempt to repeal or amend the bill. It is the 33rd time the Congress will have attempted this since the bill's passage in March of 2010. Additionally, a great deal of the change we're going to experience will be driven by economic circumstances. And I realize we don't formally refer to our economic circumstances as a depression. We call it a recession, but it's been with us for 4 years. Perhaps history will decide what it really is, but we live in a time when the heretofore unimaginable occurs. Within the last 2 weeks, 3 cities in California have declared bankruptcy. I mentioned the 3 municipal governments because there's a growing fragility of public entities, which affects the public's confidence in them, as well as impacts the stability of their workforce. The state of California has attempted to resolve its budgetary shortfalls in part by pushing previously funded expenditures off to the counties and the local municipalities. Fire districts like Contra Costa County Fire District have been subject to cutbacks that may well put residents at risk. And we're seeing daily news reporting of the precariousness of public entities that previously were perceived as rock solid. Locally in California, our governor has decided that our state will be among the very first to establish and operate an insurance exchange. Accenture, which is previously Anderson Consulting, has landed a $359 million contract with the state of California to help implement the statewide health insurance exchange. And not to be left out, in California, technology and finance industries are exploring the formulation of their own private exchanges. The state exchange will be designed to run an online market for insurance products for low to moderate income consumers and small businesses. By the end of the calendar year 2016, it's expected that the California exchange will have enrolled 4,400,000 people. Because the fine of $2,000 per employee is so much less expensive than the cost of providing employment-based insurance, it's expected that many employers across the state will just simply pay the fine and send the employees to the exchange to get their health care insurance. And the great unknown in this equation is whether the products provided through the exchange will be of equal value to the products formerly provided through employers. This will become a significant issue for hospitals as an industry, as price sensitivity of consumers purchasing a policy directly is highly likely to produce a population of underinsured. Coupled with the millions of Californians that are supposed to be enrolled in the Medi-Cal program as part of healthcare reform, we're looking at a wholesale change in reimbursement. Market consolidation is much discussed as a byproduct of the Reform Act. If the Massachusetts experience with healthcare reform is any kind of a predictor, it's highly likely that there is some truth. Industry pundits talk about convergence of healthcare financing with healthcare delivery, which is their way of saying that insurance companies will buy hospitals or physician groups or both. And any combination of those scenarios are a threat to our reliance upon our traditional geographic market. All of these things and more are potential threats to the economic stability of our hospital. However, the greatest and most immediate threat to our economic stability resides in the central unfinished business of the Affordable Care Act, cost containment. Full implementation of the Act, which includes the termination of disproportionate share allowances, occurs in 2014. At Washington Hospital, that will be a $14 million hit. The federal government's been very clear about its agenda. They have a $500 billion target in expense reduction for Medicare set forth over the course of the next 10 years. And while they are pursuing that, simultaneously, baby boomers will be enrolling in Medicare in record numbers. So that $500 million is the target, and yet you'll have more enrollees in Medicare than ever. I mean, the math just doesn't add up. And over the course of the next 10 years, this $500 million is to come from hospitals, not from doctors. They've kicked the can down the road on the sustainable growth rate question one more time. I don't know how much longer they can continue to do it, but they've been doing it since 2010. I imagine they can continue the same process. So hospitals are the source of these savings. And the message is very clear. We're going to have to do a great deal more with a great deal less. Belt tightening is going to be a recurrent and persistent theme in this coming fiscal year and beyond. And locally, the economic recovery is still yet to prove a reliable trend. The impact of our recession depression is perhaps expressed in this simple statistic, which I think speaks volumes of where we are 4 years into this economic crisis. In 2008, the average monthly charity write-off at this hospital was $827,000. In this past year, 2012, our average monthly write-off before bad debt was $2,055,000. We have 2 hospitals directly to the north of us, St. Rose and San Leandro Memorial, both of which are in immediate peril of closure. The budget for the state is problematic, with many of the painful cuts being made in healthcare explicitly as well as indirectly. The state-funded program supporting frail elderly, which I've spoken about before in this meeting, that program that helps them maintain their independent living situations was cut from the budget, not once but twice. The legislature efforts to restore that funding were vetoed by the governor. It takes a full year now or more to process an application for Medi-Cal. Discharge planning has become a critical challenge as placement of patients in appropriate post-acute care facilities consumes an ever greater effort on our part. In this past year, we had 65 patients with lengths of stay longer than 30 days, ranging in stays of 30 to 365 days. And it should be well understood that's not anything we'll be paid for. In this turbulent and at times economically punishing environment, our hospital is still challenged to proceed with some significant strategic initiatives. The facility master plan, which is tied to seismic compliance and is something over which we have no control. State law. We have the EPIC project, which is the online medical record linking inpatient and outpatient records, giving patient one record, which I think clinically is optimal. Now rises to significance as it becomes methodology to protect our income stream in the hospital and in the physician's office. And it is a very expensive and resource consumptive project. But I feel that we won't be in a position to compete in the New World Order without a system that is as robust as EPIC is. I will mention as a side note, John Muir Healthcare System has just decided to go with EPIC. And there was an article in the San Francisco Business Times about their $300 million project. Now, they have 2 hospitals and some other smaller facilities that are part, and some medical groups that are tied to them, but their price tag is $300 million. I was beginning to feel the $86 million we committed to spend on EPIC was crushing. I guess by comparison, it's not, but we still have to pay for it. The Medical Foundation is the third piece of this strategic trilogy. They provide the healthcare system with a contract-ready, responsible medical partner. And much of what exists in the law, in the Affordable Care Act, suggests that success is going to depend on having that ability. In California, you can't employ physicians directly. I think we're one of the few states left that have a prohibition against corporate practice of medicine. Most of the other states in the union, hospitals can employ physicians directly. So the Medical Foundation is our legal vehicle for accomplishing that. Any one of these three projects constitutes a significant undertaking for the healthcare system. The necessity of taking all three on at the same time is a very tall order and puts significant strain on the financial picture at Washington Hospital. Without question, the need to sustain our project, our progress in these big three projects, while maintaining strict control of their budgets, is going to be critical in the years to come. It is through implementing these three things successfully that we're going to purchase our future. So with that, I would like to ask Chris Henry, CPA, our Chief Financial Officer, to come to the podium, and while he's preparing to speak, I'll give you a little bit of information about him. He is a CPA. He attained his Bachelor of Science degree from California State University, East Bay, in business administration with an accounting emphasis. He has worked in public accounting for 4 years, after which he was certified as a certified public accountant. He joined Washington Hospital as the Director of Accounting in May 2000. In December 2003, he took over the position of Controller. Since October of 2006, he served as our Chief Financial Officer, and in October 2010, he took on the additional responsibility of being an Associate Administrator. He's a member of the California Society of Certified Public Accountants, the California Hospital Association, the Healthcare Financial Management Association, the American Institute of CPAs, and the California Society of Municipal Finance Officers. He also serves on the California Hospital Association's Chief Financial Officers Advisory Committee and is active in the District Hospital Leadership Forum. He also serves on the Board of Directors for the George Mark Children's House as Treasurer. Chris?
Thank you, Nancy. Before I get started on my remarks, I need to make a few acknowledgments. This budget is not the product of a couple of people in finance sitting together and figuring out how much we're going to spend next year. It is a product of a lot of people's work. First, I'd like to thank Nancy Farber. Nancy has spent a lot of time with us on this budget and provided leadership and vision in tackling a lot of difficult issues. So, Nancy, thank you very much for all your help with this. Jan Wood, Ed Fayen, Kimberly Hartz, Chris Lavoie, the entire executive staff and the entire management staff of Washington Hospital, thank you all. All of you put a lot of work into this. This is really your budget. Dan and I have simply gathered together the information and your input and produced a document for us to review tonight with the board. So thank you all for your hard work and diligence in getting us information. And last but not least, once again, I'd like to acknowledge Dan Nardoni. Dan, can you stand up? Dan is the one who sits at his desk starting in February, spending many hours and many weekends and many evenings pulling this all together and putting it into a form that makes sense and that we can all talk about and digest. And Dan, we couldn't do it without you. Thank you very much. So with that, we'll bring up our mission statement. And I bring this up every year as we talk about our budget, because this is the guiding principle not only for what goes on in the hospital, but every part of this organization, and it's the very basis for our budget. And this year, we'll be performing our mission in an environment that where really a new world order for healthcare organizations across the United States is beginning to evolve and solidify. After years of kicking the can down the road in Washington, in relation to Medicare, now the influx of the baby boomers becoming eligible for retirement. The bill is due and payable at Medicare. Problem is, there's no money to pay the bill, not enough money to pay the bill. And thus we have the Patient Protection and Affordable Care Act, or as we like to call it, is the ACA. And the environment really, this year, has brought really three major issues into sharp focus for us as we did this budget. And they're issues that we've talked about in the past. First, this is the year where we've seen our successful completion of our two new buildings, our Joint Replacement Center and our new power plant. And this is the year where the depreciation and interest expense related to those projects are appearing in our income statement. And there's a need to fund those two numbers. Another issue that's really been brought into sharp focus, and Nancy mentioned it, the provisions of the ACA that really are requiring things such as reimbursement withholding. What's going to happen is that Medicare is going to withhold a percentage of our reimbursement, and we're going to have to come back to them and justify why we should get that money. There's more stringent quality measures that we're going to be required to report on year after year. Enhanced documentation requirements and other provisions such as no payment for readmissions within 30 days. All of these things are really going to require a state-of-the-art information system so that we can protect our revenue stream, get the payment that's due to us. And that's really one of, in addition to the clinical advantages to Epic, one of the driving factors for our $86 million investment in Epic. The third thing that really has been made clear, and Nancy spoke to this too, is the need for a responsible medical partner. As we try to figure out how to survive in the new environment, and it will continue to evolve, and how to adapt to the unintended consequences and the intended consequences, we're really going to have that need. And to that extent, we continue to develop our medical foundation at Washington Township Medical Foundation. So, also as Nancy mentioned, the ACA, for the most part, was upheld by the Supreme Court here recently. And while we would all hope that this would end the uncertainty around what's yet to come, what's coming to us insofar as health care reform, it is only the latest hurdle, and there's one more major hurdle coming. That's the presidential election coming in November. The Republicans have promised to make health care reform a major election issue, and should they manage to gain power in Washington, have promised to overturn the law. So clearly the election is really the pivotal point as to where we're going to have an idea of what's going to happen in relation to health care reform. Nancy also mentioned, as it stands now, almost all of the $5 billion in projected savings generated by the ACA over the next 10 years are expected to come from hospitals. But CMS also is still considering major cuts in physician reimbursement, including RAC audits in physician hospitals, as well as reductions in reimbursements to freestanding medical centers that are not affiliated with a hospital. As a result of all this, for lack of a better word, turmoil, healthcare providers, including Washington, are being forced to rethink how they're going to do business in the new world. The conventional wisdom of the day is to figure out what it would take to survive on Medicare reimbursement. That's what hospitals are focused on right now. For Washington Hospital, we would have to learn to live with $285 million less in net revenue if we were reimbursed at Medicare rates. Also, Nancy mentioned the loss of DISH payments coming in 2014. In 2011, that would have amounted to $14 million for Washington Hospital. Now, the government contends that, well, we're going to have a whole bunch more insured people. Your bad debt and your charity care is going to go down. You're going to regain that. Well, we did a high-level look at that, and in 2011, if all of the $68 million in charity and bad debt that we wrote off were covered under Medi-Cal rates, and again, that's the conventional wisdom that they'll be covered at Medi-Cal rates, we would have recovered $5 to $6 million of that $14 million. So it's far short of what we'll lose in DISH. So the other thing about the law is that it's promising to provide access to care for all these newly insured. Already, physicians, many physicians don't accept Medi-Cal, or they strictly limit their exposure to Medi-Cal because it doesn't cover cost. And so this is going to leave county facilities such as Alameda County Medical Center, Tiburcio Vasquez Clinic, Tri-Cities Health Clinic, and the emergency room for these people to go. So there's an issue with that in that Alameda County Medical Center is already overrun, their emergency room. Tiburcio and Tri-Cities are very close to capacity. So it's going to be very difficult for these folks to get care. In all of this compounds the fact that Medicare already doesn't cover our cost. In 2011, Medicare reimbursement to Washington Hospital was $75.2 million less than the cost of providing care to those Medi-Cal or Medicare beneficiaries. You heard Noah talking today about healthcare plans and the aggressive tactics that they're using basically to extort money from hospitals, setting hospital against doctor, canceling contracts in the middle of negotiations. So they're fighting back, and they're trying to get more money out of us. Another tactic that I think Noah touched on is that a lot of the healthcare providers are refusing to negotiate with healthcare groups, rather than they want to negotiate with doctors individually to diminish their negotiating power. A single doctor simply has very little negotiating power against the large health insurance company such as Aetna or Blue Shield. At the state level, budget woes continue to drive cuts, and Governor Brown continues to be focused on health care as centerpiece of his attempt to balance a budget. Governor Brown's May budget revision included provisions to skim an additional $41.5 million out of the federal matching funds that are being provided by the hospital fee, and that's the fee that for-profit and private non-for-profit hospitals pay to the state. The state then goes and gets federal matching funds to get them to their upper payment limit for Medi-Cal reimbursement. But again, the governor has proposed that the state skim $41.5 million of that federal matching money into the general fund to help balance the budget. The other provision that impacts district hospitals directly is the government has proposed to eliminate $75 million of general fund healthcare spending that would come to district hospitals, and instead leave district hospitals to go to the feds directly to get 50 cents on the dollar of costs match for reimbursement for Medi-Cal. And as Nancy mentioned also, that the governor's plan has cut funding for senior in-home health care, which is directly at odds with the federal government's desire to keep these folks out of the hospital. That's reflective in the refusal to pay for readmissions within 30 days. So there's a lot of contra regulations going on right now. California has made it clear that it intends to move forward with many provisions of the health care reform law, regardless of what happens in Washington, including the health care exchange. And we don't know how that's going to work. At this point, we don't know what kind of benefits will be paid on those insurance policies, but what we do know is we're going to see an increase in the underinsured because people are going to make decisions who are not knowledgeable about health care insurance based on price rather than adequate coverage. Nancy also mentioned that the state is controlling their expenses by slowing down the Medi-Cal application process. Many, at one point, even a year ago, the longest it would take for us to get a Medi-Cal application process was 90 days. Now we have a lot of applications that have been sitting for well over a year, still waiting for a response from the state. All the additional cuts, again, in healthcare spending at the state will only serve to increase the burden of uncompensated care provided by hospitals. As with Medicare, Medi-Cal does not cover our costs. In 2009, our Medi-Cal reimbursement was $39.5 million less than our cost of providing the care to Medi-Cal recipients. So at the local level, the economy and unemployment continue to be an issue for the district, although there is more optimism for the future than there was last year when we had this discussion. We always turn to the East Bay Economic Alliance to get information about what's going on in the East Bay. This is a division of Beacon Economics that focuses on economic development, specifically in the East Bay. In their May quarterly report, the Alliance reports that the unemployment rate in the East Bay has decreased to 9.6% after peaking at 11.7% in 2010. The report also notes, and I quote, strong year-over-year growth in bellwether sectors like retail trade shows that gains in the labor market are not aberrations like some had feared, but rather part of a long-term trend in the East Bay. As always, the district has fared better than the East Bay in general. The latest, May figures from the U.S. Bureau of Labor Statistics shows unemployment in the district at 7.3%, but still unemployment a problem here in the district. And so while the outlook looks good based on the economic reports, there tends to be a lag between improvements in employment and improvements in the revenue picture here at Washington Hospital. This is driven by a couple of things. People who have kept their jobs during this protracted downturn are hesitant to take time off to take care of health care issues because they're afraid to lose their jobs. Similarly, people who have been newly employed don't want to take time off to take care of health care issues for fear of losing their jobs. Finally, we don't expect to see significant changes in PPO reimbursement in the short term. On the contrary, we think the effects of the long-term downturn will continue to hold this business in a holding pattern for the foreseeable future. A lot of this has to do with employers. We've heard a lot of stuff in the headlines. Nancy mentioned cities declaring bankruptcies. We're hearing talks about benefit costs in hospitals. We're hearing about it in fire departments, police departments. Almost every industry is being touched by the cost of benefits. And employers are going to make these business decisions, particularly with health care costs, to buy less expensive coverage that provides less coverage for their employees and less benefit. So as a result of all the turmoil that's going on at all levels, national, state, and local, we believe that the outlook for healthcare providers will continue to be challenging for the foreseeable future. This will drive, as I said, providers such as Washington to reevaluate how they're going to do business in the new market. The downward pressure on revenue is already pushing hospitals that were already frail over the edge, and we're seeing this right up the road at St. Rose Hospital. It's happening across the nation where hospitals are really getting into trouble and many are declaring bankruptcy. It's clear that hospitals that have been traditionally strong are really going to be, even in this environment, are going to be challenged. While closed systems like Kaiser may not be hurt as badly because they don't have the burden of uncompensated care that other hospitals carry. It's clear that hospitals like Washington, standalone hospitals, will need to form more strategic alliances in order to gain negotiating leverage and to gain economies of scale. And the changes, again, as I said, are driving an intensive process here at Washington Hospital to look at our business and determine how we're going to survive in the future. A lot of the things we're looking at include efficiency and cost control while maintaining quality at the highest level in the care that we provide. And several of these changes you're going to see reflected in this budget. We're looking at maximizing product lines that provide income to the bottom line to help support valued and needed services that the community needs that don't provide a bottom line, and also to help support charity care. Again, as I noted, we're considering strategic affiliations with other healthcare organizations and physician partners while maintaining our independence. We're reviewing contracts for opportunities to reduce costs. We're looking at standardizing supplies so that we can leverage our costs there. This year we joined a second group purchasing organization, and we're leveraging those two group GPOs against each other to obtain the lowest prices possible for the things we buy. We're looking at bringing down labor costs by reducing our FTEs per adjusted occupied bed and other measures to make sure we're operating at the optimal level. The other things that we've done related to salaries and wages, we've frozen hiring in departments that are over the 50th percentile in a comparative group of like hospitals. We've frozen management salaries this year. And we're just about to roll out an early retirement program. And this is just the beginning. This is going to be an ongoing process for the foreseeable future, and we will continue to dig into our operation and make ourselves as efficiently as possible. And yet, with all of this adversity and all of these challenges that are going on in the environment, this year Washington Hospital continued to achieve great things. During the last fiscal year, under the supervision of Nancy Farber and you, the board, we completed our new power plant and our new Center for Joint Replacement on time and under budget. We achieved magnet designation for our outstanding nursing program, a huge accomplishment for Jan Wood and her team and her nurses that culminated from a couple of years of very hard work. We opened the Sandy Amos Infusion Center to provide that needed service for our district residents. We achieved accreditation from the American College of Radiology for breast ultrasound and ultrasound-guided biopsy, and we were named a Breast Imaging Center of Excellence. We continued to receive a number of awards in our excellent programs. We were ranked among the top 5% for the treatment of stroke by Health Grades and received the Stroke Care Excellence Award. We were also the recipient of Health Grades 5-star awards for our neurosciences program and for back and neck surgery for the 3rd year in a row. Our joint replacement program continued receiving recognition, earning Health Grades 5-star awards for total hip replacement for the 9th year in a row, total knee replacement for the 7th year in a row. The program was again named among the top 10 in the state for the 7th year in a row and among the top 5% in the nation for the 6th consecutive year. And we again received recognition for our environmental practices, receiving the Practice Green Health Award with distinction in the last fiscal year. So again, the budget has been created in an environment that's changing rapidly, one that we're going to have to continue to be very diligent in and continue to work to adapt to the new environment. This brings us to the budget for fiscal year 2013. The budget for 2013 provides for coverage of all of our operational expenses, $506.6 million this year. Funding of depreciation expense of $24.4 million. That's up about $3.3 million this year. Funding of contributions to our retirement plan. debt service on all of our revenue bonds totaling about $16.3 million. And then operating and net income targets, including net operating income of $13.3 million, which is about 2.6% of net revenue. Total net income of $28.2 million. It provides for Measure FF property tax revenue of $8.1 million for the service on our general obligation bonds. The budget provides compliance with all of our bond requirements with a debt service coverage of 3.3 to 1 and includes new capital spending requests of $5.7 million and EPIC spending of $27.6 million. Here's a quick look at the income statement. I'll get into the details of this as we go tonight. But again, we're providing total operating net revenue expected to increase about $22 million. We have a 3.85% in this increase in operating budgets in operating expenses in this budget, and our operating bottom line again at $13.3 million. We'll start with the volume assumptions. This is really the basis for the numbers in the budget. Admissions in this budget, expected admissions patient days census data, expected moderate increases at 1.0 to 1.2%. An average length of stay increase of about 2.8% at 5.21. Deliveries are expected to increase in this budget about 1.8%. We're expecting surgical cases to increase 2.2%. This increase includes cardiac surgical cases increasing by 8.9%. That's 9 cases that we're looking to increase our cardiac program by. Increase in joint replacement cases of 23 as we build our new building and that program continues to expand. And we also have increased neurosurgical cases expected to increase at 14 as that program continues to grow. Our cath lab volume is expected to increase about 1.5% as we focus on that program and really work on improving it. That is included in that number is growth in our interventional radiology procedures as well as our cardiac cath procedures. Outpatient visits, you see about a 0.8% increase there. That's largely reflective of increased volume related to having a full year of operation of our infusion center. Quick look at some trends. Admissions increasing just slightly. The changes in admissions again coming from an increase in neurointerventional radiology of about 2.7%. We're expecting an increase in spine surgery of about 1.1%, and that being driven by a new neurosurgeon that has recently joined the Medical Foundation. We're expecting an increase in cath lab driven by increased capacity. The board has approved a remodel of our cath lab area, and we expect increased capacity there to help us with volume. We also have increases in pulmonary, gastroenterology, and cardiothoracic cases related to a new surgeon that joined the Medical Foundation this year. And again, we intend to improve our cardiovascular surgeries by 9 cases. We also have budgeted an increase in our OB cases of about 35 as our new OB group that has been growing in our Medical Foundation continues to develop their business. Quick look at patient days. We're projecting an increase of 774 patient days, about 1.2%, largely driven by the volumes I just discussed. Average daily census for 2013 expected to be at about 186. That's up from about 183 in the fiscal year we just ended. Again, the deliveries, we're seeing a slight increase in that. Again, a new group developing in the Medical Foundation, and that increase expected to be about 1.8% for the year. There's the trend on surgical cases, and I think I've been through the changes there, but again, trending up. Outpatient visits for 2013. Again, the only driver there being the full year of operations for the infusion center. We don't see big increases in our outpatient surgery in the coming, or our outpatient services in the coming year. Emergency room visits, just a slight increase expected there, about 0.5%, 268 visits based on the current trends. And this is the area where we really could see changes in impacts from decisions made at the state and national level. Also, we don't know what the future is of the emergency rooms are at San Leandro and St. Rose, but right now the situation's pretty precarious. Case mix index, we expect a slight increase in the case mix index during the year, and again, that number being driven by the changes in our volume. Quick look at admissions by payer. Really not expecting any big any changes in the admissions by payer this year in our payer mix, but again, that can change. And when we're really going to have to focus on this is 2014. That's the year when the provisions of the Accountable Care Act take place, and we're going to have to spend a lot of time studying that during the next year to try to figure out how that's going to impact our payer mix. Patient service revenue, gross patient service revenue for the year expected to increase about $205 million. That increase is coming from, of course, the changes in volume that we're expecting. And this year we are going to do a market-based rate adjustment. It's been 2.5 years since we have done any kind of significant adjustment to our pricing, and it's time to do it this year. Contractual allowance expected to change up to 75.9% from a projected 74.5%. The biggest change there coming from, of course, that market rate adjustment. Even though we increase our prices, we yield really very little of that. The yield from our market-based adjustment is about $8.5 million on about $175 million of gross revenue. So most of that goes to contractuals. So we end up with an increase in net patient service revenue for the year of about $22 million in this budget. You layer in our bad debt and provision for charity accounts, and we end up with an expected total net patient service revenue up about 3.1% at $437.6 million. Just a quick look. I spoke to this a little bit earlier, but this kind of visually gives you an idea of how our government payers reimburse us. Again, Medicare coming short of our $197 million in estimated cost by a little over $75 million. And Medi-Cal paying even a smaller percentage of cost on $68 million in cost. We expect to recover about $39.525 million. Quick look at gross revenue by payer. Again, no changes in the payer mix expected this year, but again, we'll have to take a very close look at this when we do our budget for 2014. We always like to show our room rate comparison that gives us an idea of really kind of where we stand in the market. We continue to be competitive in the market. In fact, in many areas, a little bit below average. So our room pricing is appropriate, albeit maybe a little bit low in the market. Other operating revenue for the year, really, you see a big change in our rebates and refunds number there, and that's coming from bringing on our second GPO. Again, leveraging those two organizations against one another to maximize our pricing and again, our rebates and refunds. Some small increases in the cafeteria and a small increase in Lucille Salter Packard Nursery. That's being driven by the increase in volume in our OB program. Okay, operating expense detail. Start with salaries. expect about a 12.4, almost $12.5 million decrease in our salaries. That's really what we're seeing there is the effects of our early retirement program that we're about to bring forward and attrition with our frozen hiring. We also have built into that number market and contract wage based wage increases of about 2 to 3%. And we're looking at an overall decrease in our FTEs per AOB. The benefits number increase of about $7.1 million in 2013. That's driven by an overall increase in our health and welfare costs of our health and welfare benefits expected to come in at 9% this year. Pension costs are up about $2.5 million in that number. We also have some increases in our ING stop loss insurance and our excess workers' comp coverage. We also have some one-time costs related to the early retirement program in that number. Pro fees for 2013 up about 1.6% overall. That's largely being driven by additional coverage in our internal medicine hospitalist program, and we have an increase for our audit fees this year. As the organization grows, there's more to audit, and the auditors are doing a lot more work. So we're seeing an increase in their fees this year. Supplies, we're expecting to stay pretty stable, a small decrease of about $210,000. We see that coming from savings from, of course, the new GPO and supply standardization, and that's being offset by inflation that we're estimating at 2.5% to 5%, with 9% inflation expected in pharmacy. Purchase services, we're expecting an increase of about $3.5 million, and this is where Epic is coming home to roost. The biggest driver there in that increase is coming from the staff training that we're going to have to do as we roll out Epic. That is not a capitalizable cost and will hit our operations. Utilities expected to increase slightly. Biggest driver there again is related to Epic and our IT function. We are running that system out of a remote center up in Sacramento, and we're putting together a backup center in Boulder, Colorado. And what we're seeing there is increases in communication telephone costs as a result of those centers. Insurance, we do have a slight increase in professional liability insurance related to volume increases that was offset by actually a rate reduction in some of our services, of our insurances of about 5% in our liability insurance in particular due to better experience in the last year. Marketing and advertising's changing due to some marketing campaigns slated for this budget year. Software licenses and maintenance, again, that increase coming largely from Epic as those things start to hit our income statement. Other expenses decreasing slightly as we expect to, we're looking to reduce our rentals of equipment in the year. That's a reduction of about $146,000. Depreciation. And here we're seeing the impact of our new buildings coming on. And once Epic comes online, we'll see that number jump again. Increased in interest expense, about $5.6 million. Not really a cash flow issue there. It's accounting that's driving that increase. As those projects, those large projects that we just completed come online, the interest related to those projects has to come to the income statement. They no longer get capitalized as part of the cost of the project. Cash flow stays the same. It's really an accounting thing going on there. So total operating expenses expected to increase about 3.9%, or $18.8 million. This is a quick look at the distribution of our operating expenses. Only small changes here, but of note is the change in depreciation and interest at 7%. Last year, that number was 5% of our total operating expenses, and we'll continue to see that number climb as we bring on Epic. Quick look at non-operating income. See about a 10.9% decrease in investment income. That's going to be driven by some of the spending we're doing. We're going to draw down some of our investment balances, and the interest related to that will come down as a result. Rental income expected to stay pretty stable. So our non-operating income before our unrealized gains and losses and our gains and losses on investments expected to come down about 8.9%. We don't budget for gains and losses on the sale of investments or unrealized gains or losses because that's really at the whim of the markets. So again, total non-operating income in the budget expected to decrease about 32.8%, but a lot of the impact there coming from those gains and losses and our unrealized gains and losses on our investments. Quick look at the capital budget. We're expecting total new capital requests to be bringing forward to you, our board, this year of about $5.7 million. Ongoing spending on projects already approved by the board totaling $54.5 million for total cash flow impact on capital budget spending of about $60.2 million in fiscal year 13. Quick look at some of the breakout of that. Our non-IT projects totaling about $492,000. IT projects that we expect to bring before you during the year totaling a little bit, almost $1.6 million. So really have scaled that spending down for the year to make sure we can fund the major projects that need to go on. Quick look at our major capital project spending. Our cath lab remodel, which the board has previously approved, expected to spend about $16.6 million on that. Epic spending totaling about $27.6 million, totaling $44.2 million on major capital spending. Of that, hospital funds will be used to finance about $19.6 million. And we have $24.6 million in revenue bond proceeds remaining, and that will be the end of our revenue bond proceeds for capital spending. So that concludes our budget presentation for 2013. We have a lot of challenges ahead of us in the next year and in the coming years, so we will continue to work on these numbers. Are there any questions?
Questions, anyone? Nope. Good job. Good job.
Thanks.
Trying times, but good job.
Yeah.
Okay, we are now going to move to the minutes of the June 13th, 18th, 26th, and 27th meetings. May I have a motion?
So moved for approval.
Any comments? All those in favor? Aye.
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 Opposed? Motion passes. Are there any oral communications this evening? Okay. Dr. Romano.
Thank you, Mr. Wallace. Not as exciting as all the budgetary stuff,
No.
but just as important are the credentials,
Yeah.
medical staff credential action items for June. We would like to recommend approval of the following appointments and clinical privileges for Eldon Eichbaum, neurosurgery, provisional active; Gabriel Herskew, vascular surgery, provisional active; Romy Yoon, anesthesiology, provisional active; Lee Kuo Kang, infectious disease, provisional courtesy; Robert McCabe, infectious disease, provisional courtesy; Fareed Asfour, infectious disease, provisional courtesy; Valerie Chirurgi, infectious disease, provisional courtesy; Leif Erickson, emergency medicine, provisional active; Ross Grant, medicine, provisional active; and Christina Hobson, infectious disease, provisional courtesy. We'd like to recommend granting 2-year reappointments with privileges for the following physicians and PAs: Robert Becker, MD, anesthesia active; David Bell, orthopedics active; Barbara Boyer, family medicine active; Marietta Fry, pediatrics active; Helen Ho, internal medicine active; Sandeep Kunwar, neurosurgery active; Jennifer Lai, internal medicine active; Na Lai, physician assistant, allied health. Jay Lee, internal medicine active. Sang Lee, thoracic surgery active. Victoria Leapart, gynecology active. Jeffrey Lenchner, emergency medicine active. Donna McMillan, pediatrics active. Ricardo Navarro, anesthesiology active. Hemant Patel, internal medicine active. Kutanchari Rima, family medicine active. Allison Robbins, pediatrics active. Elizabeth Trainer, pathology active. Dennis Unson, pediatrics active. And John Cecil Walks, cardiac surgery active. We would like to recommend granting reappointment from August 1st through November of 2013 for Joseph Riel, physician assistant, who was previously on a conditional reappointment. We would like to recommend resignation of Chris Wedekin as a non-reappointment. That is to say, application was not completed, so he has been deemed to be resigned according to our bylaws. We'd like to recommend a transfer in staff status category for Barbara Boyer from active to ambulatory and Kutanchari Rima, active to ambulatory. We would like to recommend discontinuing proctorship and advancing to the staff category requested for Shankar Gamiri from provisional to active, Judith Ashuri, provisional to active, Vani Velkuru, provisional to active, and Lisa Buhar from provisional courtesy to courtesy staff, not active, as stated. We would like to approve additional privileges for Andrea French for hyperbaric medicine. And finally, we'd like to recommend accepting resignations for Connie Widowson, Yvonne Murrow, Amy Lynn, and Frank Hockman.
Thank you, Dr. Romano. May I have a motion for approval of the credentialing action items?
Move for approval as presented.
Thank you. Do I have a second? Second. Okay. All those in favor?
Aye.
Opposed? Motion passes. Thank you, Dr. Romano.
My pleasure.
Sharon?
Good evening.
Service League report, please.
Yes, the Service League has been really busy again during the month of June. Our second VP and membership chairman, Fee Hugh, and myself have created a membership committee. The committee is very active and full of interesting ideas and questions. We will be doing a strategic plan for membership and staffing. This will be both a short-term needs and a long-term plan in alignment with the hospital's goals for the next 3 to 5 years. Don Pipkin, the hospital's manager of strategic planning, has agreed to guide us through this process. Additionally, we've also increased the number of Service League coordinators that we presently have. These coordinators will help strengthen the League's communication by sending out monthly emails to members in their group. We will have 5 coordinators in place. In the near future, I hope to get all the coordinators together on a quarterly basis to share best practices. The League has also successfully completed the 2010 review. We are also well underway to completion of our 2011 audit. Our treasurer, Shirley Crockett, is to be commended for handling both of these necessary financial endeavors in addition to her work as League treasurer while still volunteering in ER and holding down a full-time job. Thank you much, Shirley, for all your hard work. And we've named our newsletter The Pulse. And during the month of June, we contributed in the following special events. June 6th was health insurance. June 9th was peripheral vascular screening. June 12th, pain when you walk. June 27th, better breathers. June 28th, concerts, Central Park performance. And Relay for Life, California School for the Deaf. Thank you.
Thanks, Sharon. Any questions? Okay, Dr. Romano, your turn again.
Thank you. This is the medical staff report. The medical staff and the medical staff office remains quite busy processing applications. Although there was only one pre-application sent, we have 19 applications approved and sent to various specialties, although there are 5 in from the single cardiovascular group, also from the East Bay here, and 2 applications that were voided for having not been returned. Currently, we have 15 applications in process, having been received and are in process, and of course the 10 applications that were addressed this evening. There are tentatively 5 applications scheduled for board action next month, which brings us at present to 520 total members of the medical staff and allied health. 493 of those are active and provisional active members, and 26 are allied health and allied health staff provisional members.
Big crowd. Yeah.
That's it.
Thank you, Dr.
Sure, my pleasure.
Okay, Nancy, you want to do the hospital calendar?
Yeah, we'll go ahead with the taped presentation.
Past health promotions and outreach events. On June 3rd, Washington Township Medical Foundation and the Washington Hospital Employees Association sponsored a free book fair called Reading is So Delicious. The event was held to inspire children to read and was held in conjunction with the Alameda County Library's summer reading program. A total of 237 people attended, which included 138 children and 99 adults. On June 5th, as part of the Stroke Education Series, Dr. Ash Jane and Doug Van Houten, RN, presented Life After Stroke and Future in Diagnosis and Management. 11 people attended. On June 6th, Christy Caracappa presented Health Insurance, What You Need to Know. 18 people attended. On June 6th, in recognition of National Cancer Survivors Day, the Washington Women's Center held a seminar, Relax, Renew, and Survive. Anna Mazzei, registered dietitian and certified diabetes educator, and Karen Sindelar, certified arthritis and yoga instructor, presented. 12 people attended. On June 7th, as part of the Diabetes Matters program, Sandra Mertisdorf, RN, presented Trip Tips for People with Diabetes. 32 people attended. On June 9th, Washington Hospital held a peripheral vascular disease, or PVD, leg screening. The screening provided an assessment to determine risk for loss of circulation in legs and feet due to blocked arteries. Dr. Ash Jane and Dr. John Thomas Mahegan were on hand to provide interpretation of the screenings. 35% of the people screened were determined to be at risk for cardiovascular disease. 104 people were screened. On June 10th, Washington Hospital and Washington Township Medical Foundation co-sponsored the Rotary Chili Cook-Off held at the Saddle Rack in Fremont. The event raises funds for healthcare services in the Tri-City area, including the Tri-City Rotary Clinic, the Hope Project Mobile Clinic, the Washington on Wheels Mobile Health Clinic, and the Alyssa Ann Rushburn Foundation. Washington Hospital won Best Decorated Booth and second place for People's Choice Chili. Over 2,000 people attended. On June 12th, Dr. Ash Jane and Dr. John Thomas Mahegan presented Pain When You Walk. It Might Be Peripheral Vascular Disease. The presentation provided information to follow up on the peripheral vascular disease screening held on June 9th. The physicians discussed symptoms, diagnosis, and treatment options for circulatory problems in the legs and feet. 41 people attended. On June 15th, Washington Hospital participated in the Fremont Bank Health and Safety Fair. Lucy Hernandez, Operations Coordinator for the Community Health Resource Library, and Dave Capisi, Marketing Specialist, provided information on programs and services offered at Washington Hospital. Approximately 80 people participated in the event. On June 16th, Washington Hospital partnered with the Oakland Athletics to provide a youth baseball clinic. Participants were selected from Little League baseball teams from throughout the Tri-City area. They met with members of the Oakland Athletics coaching staff and rotated through stations where they received instructions on specific baseball skill sets. Dr. Sandeep Gupta, sports medicine physician with Washington Township Medical Foundation, spoke about baseball injuries and the proper ways to avoid injury and how to treat them if they do occur. 94 youth baseball and softball players attended the clinic. On June 16th, Sherry Kneebone, RN, nurse practitioner, and Lucy Hernandez, operations coordinator, Community Health Resource Library, attended the Afghan Community Health Fair. 53 blood glucose screenings and 31 osteoporosis screenings were performed. 125 people attended. On June 19th, Vida Reed RN presented at the Alma Via Assisted Living Facility's first annual health education fair. She addressed diabetes management. Danielle Soul, registered dietitian, and Dave Capisi, marketing specialist, also attended the event and provided information on Washington Hospital's programs and services. 55 people attended. On June 20th, Danielle Soul, registered dietitian, presented at the Acacia Creek Brain Wellness Fair, Enhancing Brain Health for Your Future. Danielle addressed nutrition and brain health. 150 people attended. On June 20th, as part of the Women's Center Lunch and Learn series, Maggie Villagomez, registered dietitian, prepared delicious and nutritious dishes for the summer salad demonstration. 16 people attended. On June 23rd, Washington Hospital participated in the East Bay Regional Parks, Healthy People Festival. The event was held at Quarry Lakes. Washington Hospital and Washington Township Medical Foundation were sponsors for this event. Washington Hospital staff participated in the festival promoting health and wellness. The East Bay Regional Parks estimates that 2,000 people attended the event throughout the day. On June 28th, the City of Fremont Summer Concert Series began. Washington Hospital is the presenting sponsor for this 6-week concert series taking place at Central Park. Dr. Stewart and Doug Van Houten, RN, spoke about the community's growing medical and emergency needs, the hospital's plan to build a new emergency department that would ensure rapid access to life-saving emergencies, and would also allow the hospital to qualify to become a designated trauma center. Additionally, they assured residents of Washington Township that the hospital is here to provide emergency and stroke care when it is needed most. As a designated stroke receiving center, Washington Hospital has high quality and comprehensive care available 24/7. And as a stroke program that is ranked among the top 5% stroke programs in the nation and has achieved the gold seal of approval from the Joint Commission, residents of the district are receiving high quality care. Washington Hospital staff was on hand at the concert providing health and wellness education and information, as well as free blood pressure screenings. All of you can count on Washington Hospital for life-saving emergency care or routine medical care, including access to the most advanced treatments for heart disease, stroke, diabetes, cancer, and other diseases. The City of Fremont estimates that 2,200 people attended the event throughout the evening. On June 30th, the American Cancer Society hosted the Relay for Life event at the California School for the Deaf in Fremont. This 24-hour walkathon raised money and awareness to save lives from cancer. Washington Hospital was a major sponsor of the event, given our focus on providing a wide range of cancer services to our community. More than 400 people registered to walk in the 24-hour walkathon, including 101 cancer survivors. More than $93,000 has been raised for the American Cancer Society as a result of this event. 31 staff members, volunteers along with family and friends, participated in the event on behalf of Washington Hospital. On July 4th, Washington Hospital took part in the City of Fremont annual 4th of July parade. The Washington on Wheels Mobile Health Clinic participated as a float in the parade which traveled down Capitol Avenue. Upcoming health promotions and community outreach events. On July 14th, from 7 a.m. to 5 p.m., Washington Hospital will host the 6th Annual Advances in Neurosciences Bay Area Symposium. Dr. Sandeep Kunwar and Dr. David Larson, medical co-directors of the Washington Hospital Gamma Knife Program, along with Dr. Moses Tagioff, medical director of perioperative and strategic surgical services, serve as course directors for the event. Speakers from across the nation will present on the latest advances in neuroscience. On July 17th, from 5 p.m. to 7 p.m., Washington Hospital will host a skin cancer screening. Dr. Sunil Dewan, dermatologist, will screen community members to potentially detect skin cancer before symptoms occur. This screening can help detect cancer at an early stage. Immediately following the skin cancer screening on July 17th, Dr. Sunil Dewan will present a skin cancer seminar from 7 p.m. to 8:30 p.m. He will discuss how skin cancer is diagnosed and treated, along with ways to protect skin from ultraviolet rays. On July 19th and 26th, the City of Fremont Summer Concert Series continues. As the presenting sponsor for this 6-week series, Washington Hospital staff will provide glucose and blood pressure screenings, along with general health information. On July 19th, from noon until 1 p.m. in the Washington Women's Center, Karen Sindelar, certified arthritis and certified yoga instructor, will present Walk This Way. The presentation will focus on ways to incorporate walking into daily routines to improve health. On July 24th, Beth Ehrlich Smith, AUD, audiologist, and Kenneth Smith, PhD, audiologist, will present on hearing loss from 1 p.m. to 2:30 p.m. The seminar will discuss factors that contribute to hearing loss and steps to take to assess your hearing. On July 26th, as part of the Washington Women's Center Evening Lecture Series, Anna Mazzei, registered dietitian and certified diabetes educator, and Maggie Villagomez, registered dietitian, will present Supermarket Savvy from 6 p.m. to 8 p.m. Participants will take a walking tour to a local supermarket to discuss healthy food choices and learn how to read food labels. The Washington Hospital Healthcare Foundation Report. On June 25th, the Washington Hospital Healthcare Foundation held its 27th annual golf tournament at Blackhawk Country Club in Danville. The event is held in memory of Jean Angelo Pisano. 238 golfers entered the tournament to raise funds benefiting hospice care and cancer services at Washington Hospital. This was one of the biggest groups of golfers in the history of the tournament. The new venue was well received. The Corporate Challenge Cup was won by Michael Wallace and the Fremont Bank team. Approximately $90,000 will go towards hospice and cancer care services. Over 300 people attended the awards dinner. On July 3rd, Dr. Ash Jain and the Jain family presented a $5,000 check to the Washington Hospital Healthcare Foundation for the Suraj Kumar and Jain Cardiovascular Nurse Scholarship. The scholarship is designated for Washington Hospital nurses specializing in cardiovascular care. The Washington Township Healthcare District Board of Directors report. During the month of June, District Board of Directors represented the district at the following community events. Patricia Danielson represented Washington Hospital at the Newark Chamber of Commerce Celebrating Business Luncheon on June 21st. Patricia Danielson represented the district at the East Bay Regional Parks, Healthy People Festival on June 23rd. Dr. Bernard Stewart represented the district at the City of Fremont Summer Concert Series on June 28th. Washington on Wheels Mobile Health Clinic. During the month of June, the Washington on Wheels Mobile Health Clinic, WOW, provided physical exams, immunizations, and sports physicals to students at Grimmer Elementary School, Kennedy High School, and Irvington High School. In addition, WOW provided healthcare services to community members at the Fremont Senior Center, Fremont Family Resource Center, Silliman Activity Center in Newark, and the Ruggieri Senior Center in Union City. The Washington on Wheels Mobile Health Clinic provided respiratory clearance exams at Revance Therapeutics, a biopharmaceutical company in Newark. Respiratory clearance exams include a basic physical exam, pulmonary function testing, and an Occupational Safety and Health Administration, OSHA, respiratory clearance questionnaire review. WOW began its free summer glucose screenings in June, which will continue through August. These screenings take place at all of the community locations visited by WOW. 141 blood glucose screenings were provided. Of those, 5% were known diabetics who will be following up with their primary care physician, and 10% were to be found at high risk for developing diabetes, and will be following up with WOW or their primary care physician. Internet marketing. Washington Hospital's website remains very active. The hospital's employment section remains the most viewed web page. Other active sections include InHealth Channel 78. Washington Hospital's cable channel 78 aired a number of new programs last month. The InHealth team continues to work on new programming that promotes health education and public awareness. Awards and recognitions. Washington Hospital has received an A grade in hospital safety from the Leapfrog Group, which conducts a nationwide survey of medical centers. The score is based on an assessment of patient outcome data in 26 different categories, including patient injuries, infections, and medication. This award is yet another example of Washington Hospital's commitment to the residents of the Washington Township and its steadfastness to providing quality and safe patient care. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070.
As most of you know, this is the time of year that Washington Hospital attends the last day of the Alameda County Fair and participates in the 4-H auction. And I'd like to invite Ken Jornstad to come to the podium and make a presentation on what we did last Sunday.
I'll tell you what I did. I lost every horse race I've been on.
Probably because you were wearing those bright pants.
Got to get into character here. All right, there we go. Now we're ready. So, as you can see by the banner or the picture here, the Alameda County Fair celebrated its centennial, 100 years of being the fair for our region here. And like Nancy said, the last day is the Alameda County Junior Livestock Auction, and that was last Sunday. And my mission, once again, was to purchase quality livestock from members of our area 4-H and FFA, Future Farmers of America. Now, letters from the participants, the kids in the pictures here, start arriving a few weeks in advance. They describe their animals, often the name of their pets, the hard work and preparing them for auction, and how the money from the sales will be spent once their animal is purchased. And I remember one of the kids came into my office, and he was a good little marketer, and he actually, I said, well, so what's going to happen, when you're done and you sell your hog? He goes, well, we have to pay the expenses, and we did artificial insemination this year, and I got that whole through process to put some money down for next year's, because I want to do this again. But 10% is fund money, and 10% has to go to charity. And I thought, wow, learning from the beginning, and it was sincere, and he knew what charity he was going to go to and all that. So I thought, okay, this is all good stuff. So as the event went on, Washington Hospital ultimately purchased 8 pigs, 4 lambs, and 3 steers. And we did buy some reserve champions. We just, so if you saw one of the ones, the reserve champions are always well marked and the best beef around. So we've got some special, and these are all going to be, kept at Washington Hospital. But the most exciting thing that happened was we got a special award. The Alameda County Fair Association presents the Carl Swizik Award, which acknowledges outstanding support of the junior livestock auction. Last year, Safeway received that, and this year, on behalf of Washington Hospital, I received it, and I wanted to just give this to Nancy. As she's the one that's been driving this project. So, again, a symbol of unselfish dedication to the improvement and furtherance of the junior livestock auction from the Alameda County Fair Association. So here you go, Nancy. I'll just give that to you to share with the board.
Thank you very much.
All right.
Here we go.
Yeah, I still don't understand how these kids don't have an emotional attachment to these animals.
They do. They do.
Yeah.
It is hard, and it's hard to watch sometimes, but it is part of their education as they participate in the animal auction, and there are some kids that have a difficult time with it. I have a tough time with it.
Yeah. Yeah.
Where are we keeping these?
Well-
You know what the answer to that question
Don't
is.
go there.
Well,
Don't go there, please.
The livestock that's been purchased will be processed and served to our patients and staff. And that's what we do every year.
I wish you wouldn't have shown me the pictures then.
Well, the kids are very proud
Now it's a
of these
personal
photographs. And it's important to them that they get this kind of recognition. And they look forward every year to sending us their marketing information, and some of them are getting quite sophisticated at it. It's fun to watch them as they go through the years. I know there was one young man years back that we bought his animals every year, and he progressed from lambs and pigs to beef. And eventually, he graduated from high school, and he went to UC Davis to learn to be a vet. And I believe that he was successful in achieving his objectives. There's another young lady whose animals we've been buying, whose objective is to become a registered nurse. And so these kids have goals, and they have an idea of where they want to go and what they need to do to get there. And they're really impressive young people.
I was impressed with the young man that Kent described, who had everything laid out, and I'm wondering, Chris, if maybe he's a potential CPA candidate.
Oh, dear. I also wanted to announce that the Alameda County Special Districts Association met today and presented a report of the nominating committee for officers for 2012 through 2014. And The member at large selected was Patricia Danielson. And she will be participating in this committee along with Mr. Roland Williams and Luis Andrade. I want to thank Pat for her active support of the hospital in our community. I also want to announce the Employee of the Month, Chris Servos. And he started his career at Washington as a per diem employee in environmental services on June 6th in 2001, and he's become a full-time employee just a few years later. He's a willing and cooperative individual, and this is reflected by the high opinion his management team and his fellow co-workers have of him. He works the third shift in the operating room department, where he completes daily terminal room cleanings. During our last Joint Commission accreditation, he was recognized for his attention to detail in preparing the operating rooms to meet our high quality standards. His dedication and specialized knowledge was instrumental in getting Environmental Services Department recognized for its excellence. In September of 2011, he was promoted to the third shift of Environmental Services lead. And so he's now trained staff on the details of terminal cleaning, as well as carpet and floor care, which is an area where he's considered to be highly skilled and expresses a strong passion. When he completes a floor refinishing job, he's known to comment, "Check out my floors, they look hot." He leads by example. He provides a comfortable, safe, clean environment for our patients, visitors, and employees. I'd also like to mention briefly, before we go to the quality report, where we stand on St. Rose, so that the community will be aware of where we are in this process. Based on a report done by Hospital Financial Services, a consulting firm that was retained by the county to look at St. Rose, we proceeded with a letter of intent with St. Rose to look at a potential management relationship, but we also decided that we needed to look before we would leap. And we advised them and the county that we would go through a process of due diligence. At significant expense to the district, we did bring an in-depth audit team here from PricewaterhouseCoopers, and over a 6-week period, give or take a few days, we did conduct our due diligence. When the results were known, they were presented to our board of directors. They were also presented to the St. Rose Board of Directors, as well as St. Rose's major creditor, Cal Mortgage, the county, and Eden Township Healthcare District board representatives and administrative representatives. For several reasons, Eden was included. One, they are a creditor, having made a $3 million loan to St. Rose, of which there's $1.5 million outstanding. And also because St. Rose resides within Eden Township Healthcare District. Having done that, we also closed the loop by meeting with county supervisors and advising them of what we had found. The results have been discouraging. The hospital loses between $15 and $16 million a year when their debt service is taken into account. Without the debt service, it's about $12 million. It is too big of a project for Washington to take on by itself, and we've advised the supervisors of that. There will be a public meeting in Hayward on August 17th at City Council Chambers between 4 and 6 p.m., which will be chaired by Supervisor Valle, and he will have a public hearing on where things stand. We also are going to be having our joint powers agreement board meet at the end of this month, which is also a public meeting, where the next steps will be taken into consideration. When this process began, stabilizing St. Rose this year was considered of primary importance. The county put $2 million on the table that was sent to Sacramento for a federal match and came back as $3 million to help St. Rose. We did the same. Kaiser had at least preliminarily indicated that it would put $3.5 million down to help. They have, to date, not met that commitment. They don't believe the situation is as dire as has been represented. We now have the permission of St. Rose and PricewaterhouseCoopers to share that report summary with them so that they can get a full understanding of exactly where this stands. The situation could not be more serious. I have indicated to the supervisors and to St. Rose that while we can't take this on alone, that we are very interested in the future of St. Rose, and if we can help, we will. But right now, I think the focus is to get Kaiser to keep its commitment and to help St. Rose, and then to begin to develop a longer-term strategy for St. Rose that perhaps we'll participate in. It depends on what the county can come up with, but $15 to $16 million a year is beyond our means. So I think the county wants to get all of the people that might have an interest in this matter together at the table and to begin to do some problem solving. So that's what lies ahead. Without an infusion of capital, a further infusion of capital this year, I don't know how much longer St. Rose can keep its doors open. It is about as dire a situation as we could ever imagine, and I think we have to do what we can to help them, but we can't do it at the price of our own hospital's financial security. It has to be something within reason. So I know that's discouraging news, but that's where we sit with the St. Rose matter, and we stand at the ready to participate in subsequent discussions and to do what it is we can to help.
Any questions about that? Okay, quality report then.
Steph?
This evening, I'm going to be presenting the nurse sensitive indicators for quarter ending March 2012. And these are the quality measures that nursing can truly impact patient outcomes at the bedside. Given a little background, these are the measures that are used to show the impact that quality nursing and excellent nursing care has on patient outcomes. The National Database of Nursing Quality Indicators is what's known as the NDQI, and that's the database where we send most of our data as it relates to Magnet. But once you participate in this database, it also meets the CMS requirement for participation and reporting of data, because that's another conduit in terms of where CMS pulls the data from. The other comparison we use is the NHSN, which is the CDC Patient Safety Database. And the measures that we're going to be discussing tonight are central lines, catheter-associated urinary tract infection, hospital-acquired pressure ulcers, patient falls, and nurse satisfaction. Looking at the central line associated bloodstream infection, for the quarter ending March, we were above the benchmark. There is definitely some opportunity here for us to explore. We have a team in critical care that's looking at CLABSI, better known as the central line bloodstream infection. The criteria is somewhat vague in terms of it's somewhat subjective. So if that patient has a positive blood culture pathogen, you have to prove that it's not related to the site or else it's considered an infection. The CDC is going to come out later on this year with new guidelines related to both the surgical site infections and the central line infections. But we continue to look at clinical practice such as line care and maintenance. Looking at MedSurg, it's the same. It's a house-wide initiative. The same processes that we have for critical care are the same processes that we have explored in the MedSurg area. And they had one infection for the quarter ending in March. Catheter-associated urinary tract infection is also known as CODI. This is one of the patient safety goals. And CMS is going to begin reporting this indicator in the next, I would say within the next 6 months. They have already given us notice regarding that. We continue to be significant improvement from the previous quarter. Again, there's a house-wide initiative as it relates to prevention of catheter-associated urinary infection. We're beginning to look on the daily rounds in terms of the necessity for the catheter. The longer the catheter stays in place, the greater the risk of infection. So we're beginning to look at that. For MedSurg area, we have had no catheter-associated infection for this quarter, again, but it's the same premise applies. And it's also part of the SCIP as well, which is the core measure for surgical site infection prevention. Looking at our hospital-acquired pressure ulcer, we continue to outperform the national benchmark as it relates to pressure ulcer. And this is the data that we submit to the NDQI. So we're being compared with all the hospitals in that database, and there's over 3,000 hospitals in that database. Plus, we are then compared to the magnet hospital within that database. We continue to have an aggressive pressure ulcer program. We look at nutrition, we look at turning, we look at decreasing the number of the layers of sheets on the bed. We're looking at daily assessment, so we continue to do a lot of work around pressure ulcer. The goal ultimately is 0. For the MedSurg area, we had no pressure ulcer for this quarter. Looking at falls, for critical care, for this quarter we had no falls. We continue to outperform both the national and the national benchmark as it relates to falls. 5 out of the 6 quarters we are better than the benchmark. In the MedSurg area, we continue to do a lot of work around falls. We have a strong falls program in terms of looking at the 4 Ps, which is the pain, potty, positioning, and placement. We now have a fall prevention program looking at during the handoff, there's a patient demonstration of the core light use, making sure that patient knows how to use that core light. This is something that has been recently implemented, and it's done at every shift in terms of the handoffs. We again looking at the medication that the patients are on. They come in and oftentimes they added new medications, blood pressure medication, sleeping medication. A lot of medication do have an impact in terms of patient safety and the prevention of falling. This is a new set of results that I'm going to be reporting tonight, and this is in our nurse satisfaction survey. It's done through the NDQI. It's a survey that's done online. They collect the data, they analyze the data, and then the data comes back to us. It's done every year during the month of May, which is Nurses Month, and they look at indicators that are related to nursing in terms of the hospital perception of, or the nurse's perception of the hospital as it relates to nursing philosophy, the model of care, the competency of the nurses, and development, just to name a few. We have outperformed all the magnet hospitals as it relates to the quality of care that the nurses provide. Looking at collegial nurse-physician relationship, we are still better than the magnet benchmark, but we have seen a decline from the previous year. So we are going back and we are drilling down on that data to see exactly what the opportunities are for improvement. We have looked at it across the board, and there is, it's slightly down in all the nursing units. So we are trying to find a cause in terms of what could have promoted that. This is nurse participation in hospital affairs. You have seen in 2011, we were slightly below the magnet hospitals. In 2012, we are far superior to the magnet hospital. Again, the nurses getting involved in shared governance, the nurses involved in decision as it relates to care at the bedside. Job enjoyment. Last year for 2011, we were better than the magnet hospitals, and this year in terms of looking at a comparison, there's even a significantly better than the comparison for the magnet hospitals. And that's about it for quarter ending March. Any questions?
Okay, Nancy, we're going to move.
We're going to make Chris talk some more. We're going to look at financials for May.
I promise I won't take as long this time. Okay. So I'll jump right into it. We're looking at operational and financial results for May 2012. Average daily census for May was down significantly. We'd expected 185.5 in the month. We saw 156. Admissions for May were 51 below budget at 1,021. Patient days were down 913 at 4,836. And you see the impact on that on the average length of stay. We'd expected an average length of stay of 5.36 for May. We saw 4.37. And an interesting thing to see here in this month is up until May, our admissions had actually been running above budget. And yet our patient days are down. So we've seen a lower length of stay all year. Looking at our utilization, case mix into the index for the month was below budget at 1.429. We had 174 deliveries, 14 more than we had expected in the budget. Surgical cases were pretty close to budget in May at 365. That included joint replacement cases that were 8 above budget at 104. Our neurosurgical cases were actually 5 below budget at 13. We did have one of our physicians that was out for part of the month. Cardiac surgical cases continued to trend lower. We saw 6 cardiac surgical cases in May. We'd expected 11. PTCA procedures were 22 below budget at 45. Our outpatient visits for the month were actually 633 above budget at 9,479. In the emergency room, still busy but below budget at 4,369 visits for the month. Looking at productivity, May saw productive full-time equivalents of 1325.1. We had 181 non-productive FTEs during the month, giving us total FTEs that were 89.8 below budget at 1,506.5. Yet our FTEs per AOB were above budget at 7.19. So the staff is trying to flex down to this big change in volume, and it's tough to get there sometimes. Moving into the financials, total patient revenue for the month came in almost $6.6 million below budget at $158,522,000. Contractual revenues for the month landed at 74.82%, giving us net operating revenue that was almost $2.6 million below budget at $40,202,000. Operating expenses for the month came in a little bit over $2 million below budget of $40,721,000, and we saw those variances, of course, in our salaries and wages with our lower FTEs. Our benefits were below budget this month, driven by health and welfare, and our supplies were below budget, and bad debt as well related to the volumes. Sorry. So we ended the month with an operating bottom line, actually an operating loss of $519,000. We'd expected pretty close to break even for the month. Non-operating income for May came in $883,000 below budget at $343,000. Of note here is the $2 million donation that we sent to the county for the benefit of St. Rose Hospital. So we end the month with a total bottom line pretty close to break even, a loss of $176,000. We'd expected $1.255 million on the bottom line. Quick look at our FASB format. This is the format used by the financial markets to look at us. Our operating bottom line stays the same at $519,000. We pull our unrealized gains and losses on our investments and our property tax revenue used to service our general obligation bonds out of non-operating revenue to come up with a non-operating loss of $598,000 from a FASB perspective, and a total bottom line showing a loss of $1.117 million for the month. Again, really that donation to the county for the benefit of St. Rose impacting that bottom line in May. So are there any questions on May?
Well, let's talk about June. And the volume continued to go down in June significantly. I'm not quite sure why. When I talk with Mac Nakayama at St. Rose, their volume is way down as well. It's hard to know exactly what's going on. In June, we saw 947 patient admissions. That's substantially below what we had planned. We had 4,613 days of care, an average daily census of 154. That was lower than May's average daily census of 156, and the high and low census ranged from 176 down to 128. The budget for June anticipated 1,095 admissions, and 541 days of care, and an average daily census of 185. So we're going to be 928 patient days of care below budget this month. The average length of stay for adults and children in June was lower than budgeted. It came in at 4.38. The anticipated length of stay in our budget was 5.06. Preliminary information indicates that inpatient revenue for the month of June amounted to approximately $107,391,000, compared to the budget estimate of $124,999,000. 48.2% was Medicare and 10.2% was Medi-Cal, for a total of 58.4% in government program revenue. The birthing center saw 154 deliveries in June. The budget was for 155, so maternal and child health is holding up its end in the budget pretty good. June's deliveries resulted in 349 baby days of care. We had 157 newborns this month, so we had some twins, I think. By comparison, there were 185 deliveries in the hospital in June a year ago. For the month of June, there were 359 surgical cases in the hospital versus a budget of 382. Cardiac surgical cases were 10 below budget, having only 3 cases for the month. And inpatient surgical activity was below budget by 63 cases. Outpatient surgeries were above budget by 40. 561 cases were seen at the outpatient surgery center. Their budget had called for 589. We had 399 cases in the cath lab, including 60 PTCAs. Total cath lab cases were lower than budget by 35. PTCAs were lower than budget by 5 cases. Inpatient cath lab procedures were 32 less than we had anticipated in the budget. Outpatient procedures were 3 lower than expected. Outpatient visits for the month of June were 2.7% below budget. They came in at 8,939. Emergency room and clinics recorded a total of 4,092 patients. The emergency room did, 4,092 patients, a daily average of 136. They came in about 133 visits below the budget. Washington, Warm Springs, Newark, Nakamura, Ohlone, and Walmart clinics saw approximately 3,592 patients during June. So our total system emergency room and clinic visits for June came in at 7,684 compared to a budget of 9,039 visits. Personnel, pretty hard to flex down enough to deal with the low volume issues. We used 1,508.2 full-time equivalents. Agency has been brought under significant control, having only 4.4 agency in the house for that month of June. We came in lower than what was budgeted in FTEs. The FTEs per adjusted occupied bed came in at 7.22 though, because we couldn't flex down enough. The budget had called for 7.01. In summary, we had 13.5% fewer admissions and 16.7% fewer patient days than we'd anticipated in the budget. Our surgical cases were below budget by 6%. Cath lab procedures were below budget by 8.1%. Outpatient visits for June were below budget by 2.7%, while ER visits were 3.1% lower than anticipated. Clinic visits for the month were below budget by 1,222 visits, or 25.38%. Total paid FTEs are below budget by 166.9, so we were able to get down by 10%. But it's very clear that if the volume remains as low as it is now, that we're going to have to make further changes. Our inpatient chart.
From the slide that was the patient day slide, it appeared that we were pretty well tracking the budget for patient days up until March.
Yeah.
And then March, April, May, and June, it just
Actually, the big drop didn't come until May and June.
well, I was just looking
Yeah.
at that patient day
It was
slide.
beginning to drift down.
Yeah, but up until March, we were pretty much on target. So just, you gotta wonder what started happening then.
Well, you note too is that admissions up until April were actually above budget.
Yeah,
So it's a real change in the service mix that's driving those patient days down.
yeah,
Yeah.
that's something
It's hard to read right now.
yeah.
I know that in prior years, we've drifted down as we've headed into the summer months, and then August and September, it begins to ramp back up. But this is more severe than what we've seen in prior years.
Yeah, it
This
is.
is very significant.
Yeah, yeah.
So we're going to be below budget in terms of gross charges, $17,608,000. It's a 14.1% negative variance. In net revenue, that's about 4.5 million.
Jeez.
Outpatient charges are going to come in higher than budget by 5.1%, or a positive variance of $1,850,000. But the total charges are going to come in 9.8% below budget. On June 30th, we had 160 days cash on hand before pension funding. The total days revenue and accounts receivable on June 30th was 61.4. The days revenue and accounts receivable excluding Medi-Cal was 56. During the month of June, $714,602 of charges were approved for charity assistance. These are people who could not pay their bills. And when you begin to put the picture together financially with what Aetna has not paid us, which is millions of dollars, what we are increasing in terms of the free care that we're providing in our community, you begin to get some sense of how one or two of those elements can really truly skew our financials. And while it is going to fall to the bottom line this year, and we can't count on what we might recover from Aetna until next year, or this fiscal year, 2012, 2013, that revenue applies to work that was done in this prior year. It's just the vicissitudes of hospital finance. It's tough. When Noah talked about the case of the patient whose care totaled in excess of $1 million, all of the care for that patient was appropriate, and certainly something that she had paid her premiums believing that it would be covered. You take $1 million and put it on the bottom line and it would help. And that's just one of the cases that they haven't paid us for. So here we are. Tough times ahead. Nobody's offering to pay us more, and everybody is expecting all different kinds of things in excess of what exists now in terms of programs and financial controls that the feds want to levy. This is going to be a tough year. There's no two ways about it. And it's very clear with what Aetna has done, picking off doctors as individuals, even though their contract resides with HealthGuard. They're trying to intimidate the doctors individually. I mean, it's going to be a tough year across the board for physicians and hospital alike. This is just the beginning. So we're going to have to tighten up rigorously on our operations. We're going to have to look at programs that we historically have provided at no cost and decide whether or not we can afford to do them in the future. When you talk with the guys from PricewaterhouseCoopers who've been all over the country looking at hospitals that have suffered the same fate as St. Rose, where they don't have the money to keep their operations going, it's the frailer hospitals that are getting there first. But if we persist in the policies of non-payment or underpayment that are being levied against hospitals and physicians, there isn't any healthcare system that can withstand it over the long haul. Doctors in the West Bay are beginning to refuse to take Medicare assignment. Most doctors won't take Medi-Cal in their office, or if they do, they simply do it as straight charity care because it costs more to bill for the Medi-Cal patient than it does just to give the care for free. That's how low the reimbursements are. So when they talk about putting millions of Californians into a Medicaid program at Medicaid rates, you're talking about a whole bunch of people all dressed up with nowhere to go. There aren't enough clinics in the state to accommodate those millions that will be enfranchised but have no access to physicians. So, a lot of what's happening right now doesn't make any sense. And it just doesn't add up.
Something's got to give.
Yeah. And we have to be smart enough to see it coming and take advantage of it. And historically, we've done that. I mean, 20 years ago, at the advent of the big managed care stuff, everybody said standalone hospitals didn't have a future. And, oh, gee, that's too bad, Nancy, you just became CEO of a hospital that has no future. This is what my colleagues were telling me. And yet, in the past 2 decades, we have enjoyed the greatest growth and the greatest revenue generation in the history of the hospital. And that was a time when everybody said we had no future. I'm convinced that with the management team that we have here, that we will find our way. It will be like picking our way through a minefield, but I think we have the raw talent here to take advantage of what we can take advantage of and continue in our commitment to the residents of the district. That's the strategic agenda, is picking our way through that minefield.
All right, then I think with that, we're going to move to the action items. Dr. Nicholson?
Item A, Mr. President, I move for adoption of resolution number 1122, which is the budget estimate for fiscal year 2012-2013. This resolution provides for the necessary funds required for the operation of the district and for the continued support of the Washington Township Hospital Development Corporation in its operations to promote the charitable and community service mission of the district.
Second. Okay, we have a second. Any questions? Okay, all those in favor? Aye.
Aye.
Opposed? Motion passes. Item B.
Item B, Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to accept the bid amount of $823,341 received from James R. Griffin, Inc. for the pharmacy remodel project and to execute the contractual documents to complete this project. This project was approved by the board on April 13th, 2011 by resolution number 1108, pharmacy remodel project.
Thank you. Do we have a second?
Second.
Okay, any questions or comments? Okay, all those in favor? Aye.
Aye.
Opposed? Motion passes. Okay, at this time, I want to thank all of you. We're now going to adjourn to the closed session. Okay, welcome back, everyone. We're going to reconvene the open session and announce that no actions were taken during the closed session. Is there any other business this evening? Seeing none, this meeting is adjourned. Thank you.